My name is Jonathan Sembrano, and our symposium today will be on the L5-S1 level. And just to give a brief background, for the first several years that Solus was meeting every year, we sort of have ignored the L5-S1 level because the teaching was that it's a level you cannot reach with the lateral procedure, and so we just ignored it, which really does not make sense because a lot of the fusions that we do would need to involve the L5-S1 level. So by turning a blind eye, it does not make the problem go away. And I know that a lot of surgeons, they have their own issues with either T-lift or an A-lift approach. And so this is a hot topic, and I'm glad to see that a lot of people are pushing the boundaries and addressing this level lateral position. So I know it's a little bit of a repetition of the debate run I had last night, but for such a hot topic, I think repetition is good, and it'll be great to hear from a lot of other experts. Unfortunately, Dr. Blaskiewicz is unable to make it, but Dr. Bob Eastlack is very gracious in stepping in. So the first talk will be, I prefer to flip my patients, to be given by Dr. Eastlack.
The naysayer. All right, in full disclosure, Don made these slides. So these are not my disclosures, they're Don's. So other disclosures that are relevant, Don regularly performs single position surgeries, as do I. He performs bilateral pedicle screws when feasible, as do I. He's had to bail on bilateral pedicle screws, as have I. He's performed pelvic bolts in the lateral position, and most importantly, as with me, he's a big fan of Ivan Chang. So lateral interbody fusions and ALIFs are widely accepted techniques at this point, but they often require posterior supplemental fixation. And this often requires repositioning in yesteryear. The time consumed in the operating room in flipping patients varies by institution, but the reality is it does take time. And that adds to both the cost of the surgery, given the time value in the operating room, as well as the physiologic duress of anesthesia on the patient. And so single position surgery brings to bear some improvements in those regards. There's very little out there yet. You're starting to see some data come out on its beneficence. And at this point, there's a clear marketing push in that direction and zest from the surgeons that it may improve our patients and our lives. This one limited study by Zeno, you see, is a cohort study, single position versus lateral, then prone positioning after lateral interbody, 42 patients in the single position group. And you can see here that they demonstrated a time savings of about 45 minutes per patient using the single position technique. That's real time. So something to be considered. Now, this obviously doesn't go into all of the other nuances, the radiographic outcomes, the clinical outcomes, but there's something to be had there with respect to time value. Right now, we have guys like Dr. Buchholz, who is a stud, doing these surgeries and performing relative miracles with respect to the time. But there's some limitations. At L5-S1, which is really the focus of today's discussion, doing the posterior screws is not as easy as it might seem and not necessarily feasible in all circumstances. Targeting the S1 pedicles with a high pelvic incidence or steep sacral slope may not be feasible with the current table that you use. The targeting of the pedicles is often limited by the table pedestal. Unless you have a fancy $250,000 table, you may not easily be able to accommodate that. So then you're stuck in your office planning the surgery out, but not really knowing if you're going to be able to feasibly get there in the operating room. And that creates a whole level of frustration that you might avoid just by having a consistent posterior prone positioning. You could be having to identify these pedicle sites, and then you get in the operating room and bam, you got your pedicle blocking your ability to achieve a parallel nature to the cannulation of the S1 pedicle. So Practically speaking, sounds great, but in practice, in a certain group of patients with certain tables like you see here, it may not work out in such a way. So something to be considered. All right, so solutions. There are these radiolucent tables. They can allow for you to do both things. But again, these are not available everywhere. They're very expensive. And so if you don't have that, you're going to be thinking a lot more than you probably want to preoperatively about what's feasible. So what about the ergonomics? As we just heard, it's not easy on your shoulders and your upper extremities to put these in. Another point of contention is it's very difficult to do these simultaneously. Prone position, because the ergonomics are easier and gravity is helping you a bit, you can often marry a lot of the imaging and a lot of the steps into combined shots. For an example, you can put screws in bilaterally in a concurrent fashion, so you may pick up time versus the lateral. Robotics may change that a little bit in terms of workflow, but right now that's been poorly contemplated. If you are a training institution or you have a dual surgeon circumstance, having two surgeons work in the single position lateral is not so easy. Versus a prone position, it's quite easy to have two surgeons working simultaneously, both during the execution of the procedure as well as closure. So ergonomics of placing screws in the lateral decubitus position is somewhat explained by this fancy arrow shooter. The position on the table requires more planning. You have to have your team or yourself more involved in making sure that they are properly rotated, properly positioned posteriorly. It is not as easy to abdicate that responsibility to less experienced members of the team. And the under screws, the downside screws, are quite difficult. They can, depending on the size of the patient, the position of the patient, relative to the front and back of the table, can be very difficult to accommodate, and the ergonomics are quite challenging for those. So if you can't get them in, do you compromise the patient's outcome, or do you have to flip them anyway after you've already done one side? Things to consider. How about sterility? Not really well discussed, but anybody who's done lateral single position surgery knows that the C-arm is more likely to be involved in contamination. You've got to wrap that in different ways. And even the sterility of the surgeon is to be questioned. There's one of the there's Don losing his pants. The reality is that when you look at sterility, there's a safe zone, and this is somewhat data-driven. It is contamination or colonization-based data, but nonetheless, is this really what we want to have to dress like to get our lateral single position done? There is a sterile zone on our gowns, and it does not go down to the point where we're typically working for a lateral single position. If you look at the study that was utilized to base this safe zone, we see both a variance in the amount of colonization with the type of approach. Thoracolumbar posterior approaches had the highest colonization at 54%. The primary surgeons typically had more contamination. And interestingly, those gowned with lead, so that would be us for the most part, had an 82% contamination. So we're already working in a dirtier environment. If you look at the bacterial growth from these contamination areas, the farther you got away from the safe zone, which is chest to waist, the more contamination we saw. And you see below, basically table and below, starts climbing 17% up to 22% below the knee. So there's a problem working low, that's the bottom line. And that really didn't even contemplate the issues with the C-arm, which add another layer. Wound closure, anybody who's done single position knows that's a pain in the rear in relative terms. Your arms are tired. Do you do as good a job? Do we really want to sew in the lateral decubitus position and get conditions like this? So in conclusion, single position surgery is certainly feasible. It seems attractive from a time input perspective. It may have the capacity to reduce those operative times, but there's serious technical challenges in providing consistency and reliability in executing it. And sterility is yet unaddressed. It may be an issue. It may be that the MIS portion of the procedure overcomes that challenge, but contamination should be considered as we move into this realm. Thanks, Don.